So glad to have you with us this evening. Welcoming in back to the show, Paul Seegert, managing partner at PCS Advisors. It's PCS Advisors on Twitter. Thank you so much, Paul, for coming on.
Happy to be here. Thank you.
So, wow, differences in prices, disparities actually, for routine procedures that involve X-ray equipment. Tell us what this is all about.
Well, there's just a basic lack of transparency in the pricing of healthcare procedures, and these complex imaging procedures are a pretty good example of that, but it's broad and throughout the system. When you get behind the transparency rule that hospitals, for the most part, aren't complying with, you see that they might have 150 procedures for 150 different prices, rather, for any given procedure. And it depends what your health plan is, what you might pay, and it can be a tenfold difference. In fact, I was looking at an MRI for an employer in Dallas, Texas. It could be anywhere, though. And they were with Blue Cross Blue Shield of Texas. And you could go to one of 10 different places within 25 miles of this employer, all in network. You wouldn't know it if you were a member of the health plan. You were going to pay your $100 copay regardless. The low-cost provider would turn around and bill the plan $700, and the high-cost provider would charge the plan $7,000. All in network, completely behind the kind of the scenes or behind the curtain in terms of what the consumer would see. But your share of cost as a consumer was the same. So you had no ability really to consume well. And then at renewal time each year, as a consumer, you kind of scratch your head and say, why are my premiums going up so much this year? And it's because of these kinds of things that are going on behind the scenes in the way that we pay for healthcare in this country.
So there have been legislation passed that mandate transparency on these prices. We know that if you look at the data over time, you can take any slice of time and you can go across the country and look at what providers paid for that procedure, and you can come up with this is how much this costs, this is how much that costs. We know that work can be done, but we don't have anyone actually doing that. So for consumers, even if you have health insurance and you think, well, this doesn't really impact me, you just described how it does. It makes your premiums go up. So what is the solution here? Because I think it's absolutely ridiculous that one person would pay $700 and another would pay $7,000. That doesn't make any sense because they're at the same facility using the same machine.
Well, I think a big part of the solution is transparency. But even when we pass rules or create laws, rules, whatever, that require transparency, we don't seem to enforce it. Right now, hospitals are supposed to be transparent. It was actually one of the good parts of the original Affordable Care Act that hospitals would publish their pricing for 300 common procedures. And the goal was that as consumers, we could know what healthcare cost before we consumed it and consume well, which even for our own share of cost, if we're in an HSA-style plan, as an example, that's important. It's important regardless, but especially in those kind of plans. And you fast forward to today, 12 years later, the hospitals fought it in the courts for 11 years. They finally lost. And under the prior administration, it was required that they would start publishing their pricing. And January 1st of last year. Fast forward to today, 0.5% of hospitals in the three largest chains are actually in compliance with the rule, 0.5% of their locations, because the fines are just really insignificant compared to their revenue. So you have rules, but you don't really have enforcement of those rules. So the hospitals aren't complying. And then you have another rule that kicks in that says, well, health plans should report what they are compensating these hospitals. And again, you don't really have good enforcement. In the format that the data comes in it's just such a mess. When you have hundreds of prices and it's not even just one insurer that has a different price. with that facility can have different prices. It becomes just super hard to track. And as a consumer, we don't give you the right incentives. We don't reward you for consuming well when it comes to healthcare. You have a copay, you have a deductible, you have coinsurance, but they have no relation to real cost. So we've done a good job of taking the American consumer, which is a really powerful force, and disarming them really, and not giving them good rewards for good consumption. And that's created a situation where you have many players that pile on and capitalize on that.
It's something, because when you talk about, okay, we passed legislation, and they're like, yeah, but the fines aren't really strong enough, so I'm just going to keep on doing what I'm doing because I'm making so much more money doing that. And in this article here that you shared with us from Market Watch, you are talking about a CT scan costing as little as $134. I remember when I was having them, when I had a prolonged illness and I used to have CT scans, and they were charging my insurance company $1,800 a pop. It didn't matter where I was getting them. That was the allowed charge that they were charging. You're saying they can be as cheap as $134. Man, my insurance company could have saved a lot of money if we paid $134 per scan instead of $1,800.
Well, yeah, and what we've done is create a situation where insurance companies actually do better when the cost of care is higher. With the Affordable Care Act, we told these insurers, so long as they spend 80 or 85 cents of every dollar they collect in premium on a claim, they could keep the balance. So we misaligned the incentives where insurers actually do better when claims costs go up, and then we ask them to go in and negotiate pricing on our behalf as consumers. I mean, if you get to be in a cost-plus model, are you in the best position to negotiate the lowest price? And, I think the answer is pretty clearly no, especially when you look at a lot of these facilities, and you mentioned this $1,800 procedure. You can call up a lot of these facilities and say, what would you charge cash for a CT scan? And they'll tell you $287.
What?
And then if you pull out an insurance card,
gosh.
You pull out an insurance card and all of a sudden a zero gets tagged on the end of that, and then they apply your discount. You start to realize this isn't a straightforward procedure in terms of how we bill for these things.
So on the one hand, I'm super glad that the United States medical system is what it is, because we don't have to wait 9 months to get a CT scan like some people in Canada. You can have your scan the same day, and sometimes, depending on, what time the doctor orders it in the morning, you can have your choice. This facility is 3 miles from you. This one is 7 miles from you. This one is in a place that has a whole hospital system with the Starbucks in it. You might want to go there and do it because you're going to be hungry after because you have to fast all the way. There's a lot to it. So isn't one of the solutions, I'm just thinking, couldn't you have legislation that required the publishing of the bills and maybe make the fines in line with what health insurers actually call real money? Because the fines are obviously too small. Yeah.
I think that's the intent a lot of times when these rules get created, but then lobbying is effective still. People ask me all the time when I'm on various news outlets, so when will this get solved? Well, when the lobbying isn't effective anymore is probably the real answer. But, you have a fine for the hospital transparency rule. The fine started out at $300 a day. I mean, when you know the numbers that hospitals work in, at least real hospitals of size, it's billions of dollars a year. $300 is you're basically telling the hospital, we're not really concerned if you comply. And then you up it to $2 million max a year. That too it's real money for a person's household budget, but not for a hospital size. So we still haven't made it a real rule. I think 2 hospitals that I'm aware of have been fined in the country, and lots are not compliant. So we're not really approaching it in a serious way. And then you have the fact that we actually ask private payers to subsidize government payers. You've got all these different folks that can show up at a hospital. If you show up and you have Medicare or Medicaid, the hospitals are willing to lose money on those clients because they know someone's going to show up with insurance they got from their employer or a private plan, a commercial payer, and they'll charge them much more. RAND Corporation just did a study. They looked at the data from 4,000 hospitals out of the 6,000 that we have, and they confirmed yet again, private payers, commercial payers, are carrying the water. They're providing the profits for the system. They pay 224% of what you pay, of what a Medicare or Medicaid person pays when they show up at that same facility and get the same procedure. So that kind of makes you think, well, shoot, the government that's supposed to be protecting all of us as consumers kind of has a misaligned incentive as well, in that they are passing the rules for transparency and all of these things, but they are underpaying these providers, and that just creates a sticky situation in and of itself. That they're getting subsidized by the people they're supposed to be protecting.
And so none of it actually works to improve the care or anything having to do with what patients are getting. And I'm not saying that hospitals are, not providing good care for the money, but the idea that you have that huge of a disparity in what people are being charged, or that you can simply say, well, I don't want to use my insurance, and then they're like, oh, well, then it's $100. You're like, wow.
Yeah.
Oh,
yeah.
Thank you. You feel grateful. Thank you so much. I just want to be able to afford this. I just don't want to carry these medical bills. There's a lot going on that people just don't know. Most people don't know that, Paul.
Well, we've got this disparity between payers, and we have the government who's supposed to be kind of setting the guideposts for the whole system and making sure no one gets taken advantage of, who's getting subsidized by people in employer plans and private payers, commercial payers. And that is a dwindling pool. Only 49, if you go back to 1999, 67% of us got our coverage at work. This is something that has been on my mind a lot lately, because I think we're headed down a road that's not sustainable. It used to be 67% of us got our insurance at work. So when the minority of payers were getting subsidized by the majority of payers, the 67%, it worked. Just this year, we passed a threshold that I think is pretty significant. 49% of us now get our coverage at work. And 51, that means, of course, don't. The 49 are the ones getting charged more to make up for the others whose reimbursements don't cover the cost of their actual care. And it's a dwindling, and that number continues to fall. That trend is pretty strong and pretty steady for more than 20 years now. So how are we going to keep this up when it goes to 40 and 30 and 20? I mean, as we have less and less that are having to pay above what it takes to cover the cost of their procedure plus profit, to make up for those who are not paying the cost of their procedure, even just the cost, never mind profit. That's a recipe for a pretty tough situation.
It is. So now, I guess going forward, with those numbers trending in the way that they're trending, we're going to see more Americans ending up in either, so government plans under the ACA or alternative health, like health sharing. That's a growing industry where people are gathering together in groups and like-minded. Yeah. But I think, so there's something good about that. There's more transparency in a health share because it's regulated as a not-for-profit. Obviously, the ACA, you don't have you can't keep your doctor, you can't keep your plan. Those were all lies. But if you're already in there and you're getting that big old subsidy, you might be feeling pretty good about it.
You're not feeling the increases. that are coming right now.
No, but you also have substandard government health care. But, I mean, you get what you pay for. So where do you see the end? Because we have a lot of things at play here that also impact the health care market. We have a recession. I know everybody's saying next year we're definitely going to be in a recession. We're in one now. I just believe that it's the same measurement tool no matter who's in the presidency. So you have the recession, you have record high inflation, and you have people dropping out of the labor force, which those people, by virtue of not having employer-based care, are in that market that you were talking about, the one that is now the majority. We really need good public policy on this, and we need people to be more aware of the options, I think.
I agree. And when you put into this whole conversation the fact that more than 50% of U.S. hospitals are going to post a loss this year, it's a scary situation. I mean, you have hospitals and insurers that negotiate multi-year, and not just hospitals, but providers at large, that negotiate multi-year contracts with insurers on what the reimbursements are going to be. And then you watch inflation and the staffing shortage we had coming into this whole pandemic era that we've gone through, that it was worsened. I mean, their costs have gone up tremendously, and they have continued to get level reimbursements. I think it's 53% of hospitals are going to have an operating loss this year in this country. And you can be sure they're going to come to the negotiating table as these contracts come to an end with aggression, and they'll have to. And then you look at the fact that insurers, the 4 or 5 that are left, and to use too big of a word, oligopoly that remains of these insurers, have stock prices that have gone up on the low side 400% or 500%, on the high side 1,000% since the Affordable Care Act kicked in. I mean, we've got a situation that we've created where in the last 12 years, deductibles have grown 87% for average people, for all of us. And premiums have gone up that much for many. And we put 100 million Americans in medical debt. There's far less than that without insurance. So most of them have insurance. And we put 100 million Americans, most of whom have insurance, in medical debt. And we have 53% of the hospitals that are going to lose money this year, basically. And insurers have been fantastic. I mean, we have a clear lack of transparency, and people might point to it and say, well, this isn't a capitalist. I mean, capitalism is at fault. I don't think so, because we don't have a free market in healthcare. When you don't have access to information freely and transparency, that's not a free market. If as a consumer, I don't know what things cost before I consume them, that's not a free market. I can't compare pricing between different locations. It's not a free market. We need to create a free market. We've done it so well in so many other areas. We can do it in healthcare too. That's really what motivates me to stay up late and get on an interview, to get up early and go to work. We need a free market in healthcare. We don't have it. If we would just apply the things we've learned in so many other areas to healthcare, I know we can do a great job with it. Well,
I know we can. I echo your sentiment, and I'm so glad you decided to join us tonight to talk about this. I know you have long days, and I'm with you. I work in the day, and then I also do the show at night. So it is a commitment to have you come on. We are so grateful for your time. Also, your expertise on this. We need this information so we can make better decisions. Paul Seegert, Managing Partner at PCS Advisors, at PCS Advisors on Twitter. Thank you for joining me tonight.